Okay, very good morning to everyone and welcome to the CPC from Department of ONG. With me today, we have three speakers, who is Dr. Rafi'uddin from Department of ONG, Dr. Erica from Department of Radiology, and Dr. Chiu Kartik from Department of ONG. What we are going to present today is a case of a young woman who presented to us with a huge abdominal mass. So in a young woman, when there is a huge abdominal mass, definitely we have to come in and decide on what is the differential diagnosis, what is our provisional diagnosis, what are we going to do with this young lady, and don't forget, this is her beginning of reproductive life. So it is very important for us to know what is a provisional diagnosis and we manage accordingly. So with that, I would like to welcome our first presenter, Dr. Rafi'uddin, to start off with the case presentation, followed by Dr. Erica, and then Dr. Chiu for the run-up. Welcome, Dr. Rafi.
Thank you, Prof. Lim. Allow me to share my screen. Assalamualaikum and a very good morning. So I'm Dr. Rafi'uddin, Registrar of Obstetric and Gynecology Department. Today we will be talking about the case of this geminoma. So I will have the honor of starting the session with the case presentation. So before I begin, this is the outline of my presentation today. I will start with the introduction to the patient, then we will talk about the differential diagnosis. Following that, I'll share about the physical examination findings as well as all the investigations result. And lastly, we will go to the treatment plan that the patient has already undergo. So for introduction, our patient is Miss Zax. She is a 22 years old, single, sexually naive with no non-medical problem or previous surgeries. She first presented on 14th of November 2022 with complaint of 1 month history of abdominal distensions, worsening with 5 days history of epigastric pain. The pain is pricking in nature, intermittent and non-radiating. So at this juncture, we were already thinking of several differential diagnoses. The history of abdominal distension may suggest abdominal fluid accumulation or organ enlargement. And when abdominal distension is associated with epigastric pain, it can be a sign of compressive symptoms, which in this patient's case probably causing stomach acid reflux. Thus, in this case, differential diagnosis includes a uterine tumor, ovarian tumor, GI tumor, tuberculosis gut, as well as liver disease. To determine the diagnosis, further evaluation including detailed history taking and physical examination, as well as lab investigation and imaging studies is vital. So in the case of uterine tumors such as fibroids, it is one of the most common type of tumors found in the female reproductive system. They can cause significant abdominal distension as well as compressive symptoms as they grow and press against other structures. Thus, patients will usually have compressive symptoms such as abnormal bowel or urinary habit, as well as early satiety and refluxes. So if the mass involved endometrial lining, there will also be abnormal uterine bleeding. And if patient presented with history of rapidly enlarging mass, it should raise the suspicion of malignancy. This is also true if the mass is painful. So physical examination will usually reveal mass arising from the pelvis, which is unable to get below, with restricted mobility and firm consistency. In the suspected ovarian tumors, including both benign and malignant types, they will usually produce a similar symptom with uterine tumor. However, if the pain is severe, with presence of peritonism on physical examinations, ovarian cyst accidents such as torsion and rupture should be suspected. Pelvic mass that is able to get below, mobile with cystic consistency is very suggestive of ovarian in origin. For GI tumors, they can cause significant abdominal distension, pain, as well as bowel-related symptoms such as constipation and tenesmus. Physical examination is highly suggestive, especially if the mass involves upper abdominal region. Rectal examination is also compulsory to look for lower rectal mass. In women with TB gut, detailed history taking is of utmost importance. History of sick contact should be inquired. High suspicion should be advocated if patients work with foreign workers. Presence of prolonged cough and night sweat accompanied by constitutive symptoms is indicative of TB infection. While physical examination usually has no specific findings, they could possibly be palpable lymph node indicating TB infections. In women that appeared jaundice with significant history of bleeding tendency, abnormal stool or urine color, as well as history of taking traditional medication and alcohol, liver disease should be suspected. Stigmata of liver disease in physical examination should be looked for to exclude the problems. So in the case of Ms. Zex, further history taking revealed that she only noticed her abdomen to be distended in the last 1 month prior to presentation. Otherwise, her menses remain normal. She doesn't have any loss of weight or appetite, no lower abdominal pain, and bowel and urinary habit has been normal. There was no also rectal bleeding, no prolonged cough or night sweats, no pale colored stool or tea colored urine, and she denied any taking of herbal or traditional medications. So these are the other history that we can obtain from Ms. Zex. She attended menarche at the age of 12 years old. Her menses has been regular and normal. She works as an admin executive with diploma in business studies. She's not smoking and doesn't take alcohol. And both of her parents are healthy as well as her siblings. And there's no family history of malignancy in the family. So when we did our physical examination, we found that she stood at the height of 152 centimeter with weight of 65 kilogram, with BMI of 28.1 kilogram per meter square, which is overweight. She was not pale, not jaundice, the hydration was fair, but pressure was 124/81 millimeter mercury, which is normal and safe. However, her pulse rate was at 142 beat per minute, which is tachycardic, and she was febrile with temperature of 38.2 degrees Celsius. Neck and breast examination at the time was normal. However, lungs auscultation revealed reduced at entry by basally. Cardiovascular examination was normal with no JVP raised, and lower limbs was normal with no edema or calf tenderness. Abdomen inspection revealed distended abdomen from the suprapubic until midway between umbilicus and xiphi sternum, while the umbilicus is centrally located and there was no visible scar. Palpation revealed a soft abdomen, non-tender, with pelvic mass palpable at about 30 weeks gravid uterus size, which is cystic in consistency, irregular border, able to get below with limited mobility due to its size, while percussion revealed presence of fluid trail and shifting dullness. There was no vaginal examination done because patient was sexually naive. However, we did a prerectal examination that was a normal finding. So at this juncture, our preliminary diagnosis was possible ovarian malignancy, as well as sepsis for investigation with differential diagnosis of infected ovarian tumor, COVID-19 infection, as well as tuberculosis. So we supplemented our assessment with laboratory investigations, full blood count showing leukocytosis with white cell of 13.2, but the hemoglobin and platelet level is normal. Renal profile is normal. However, there was a prolonged coagulation profile with PT and APTT raised. Liver profile showing trans with AST of 111, and blood gases was normal at the time. And we supplement with another investigation, which is the tumor markers, which shows highly suspicious elevated level of CA125, 502, and the LDH is extremely high, 5,672. There was also COVID-19 swab taken, which shows positive. So we added our diagnosis with COVID-19 pneumonia, as well as transaminitis with prolonged coagulation profile for investigation, with the differential diagnosis of liver injury secondary to sepsis or primary liver disease. We proceeded our investigation with chest X-ray, which shows bilateral pleural effusion, as we can see here in the pictures. And then we had our transabdominal scan on pelvic ultrasounds, which shows uterus anteverted, measuring 7.4 times 3 centimeter, which is normal. Endometrial thickness of 4 millimeter, which is also normal. However, there was presence of pelvic mass measuring about 20 times 13 centimeter, which is huge, with solid cystic appearance and solid area measured more than 10 centimeter. There was also presence of papillary projections. However, there was no increased Doppler uptake. There was also evidence of ascites seen on the ultrasound scans. So using IOTA at next model, we estimate the probability that the tumor is either benign or malignant, and we get to the point that the risk of malignancy is up to 96.8%, which is very, very high. And based on the IOTA at next model, we can conclude that the tumor, the malignant tumor, is at least stage 2 and beyond, and not a stage 1 disease. Subsequently, we proceeded with our investigation with CT, thorax, abdomen, and pelvis. So for this part, I would like to invite Dr. Erika from Radiology Department to explain about the CT scan findings.
Thank you, Rafi. Allow me to share my screen. Yeah, can I confirm that you see my slide?
Yes.
No, Dr. Erika, just the background. Ah, yes, we can see.
Yes. Yeah.
Oh, all right. Kejap, I close my. It takes some time.
All right.
Okay. All right. So good morning. I'm from Dr. Erika from Radiology Department. So this patient has got a chest and abdominal radiograph done on first day of admission, and this was the abdominal radiograph showing that there is paucity of gas in the abdomen. As you can see in the center of the abdomen towards the left side, there is mostly opaque. Okay, no air-filled bowel in the left side of the abdomen down to the pelvis. So this kind of finding usually means that either the large part of the bowel is completely filled with fluid so that there's no air seen, or there is a large mass displacing and collapsing the bowels next to it. So in this case, when you correlate with clinical findings of a large mass, you know that the reason is actually a mass. And this X-ray again shows, Dr. Rafi showed it just now, bilateral fluid effusion. But lung-wise, there is nothing much to, not much changes seen, right? So just bilateral fluid effusion. And on the second day of admission, contrast enhanced CT, thorax and abdomen was done. And this was axial cut on your left, showing a large mass predominantly situated towards the left side of the abdomen. And you can see over here that there are, this is a mixed solid cystic tumor, but predominantly solid, okay? Predominantly solid. The peripheral part is more cystic and with multiple small locules within. And the arrow here shows an enhancing septa that separates the lobule-like appearance within the mass itself. And on coronal scan here, we again see the same kind of finding. And over here, you can see that the lobule in the middle here is lined by a thin enhancing septa. Okay, the yellow arrow points towards the septa. And these are the cystic component, and the large cystic component on the left, on the patient's right side. And this mass measures about 22 cm from the upper abdomen all the way down to the pelvis. This is a reconstructed CT image in coronal oblique view, where in maximum intensity projection to show the vessels. All right, so what we have here is the yellow arrow points towards a vessel that drains the large tumor into the red arrow here points towards the IVC, the inferior vena cava. So a vessel that drains into the IVC on the right side, by anatomy, it is the right ovarian vein. All right, in a man, it will be a testicular vein. In a lady, it is an ovarian vein. So this ovarian vein, when it comes from the right side, it indicates that this mass, although it is predominantly towards the left side, is actually arising from the right ovary. So this is a right ovarian mass based on the enlarged right ovarian vein that drains it. And another supportive evidence is we actually saw the left ovary in the pelvis, but the left ovary is also not normal. it is enlarged. It is enlarged and shows the a mass-like configuration with multiple small cystic components within it. So this is the uterus in the middle, suspended by the broad ligaments, and you can see that there is gross ascites in the pouch of Douglas in front of the uterus and also around the liver, and together with pleural effusion again demonstrated. So in conclusion, for the imaging part, we have bilateral solid cystic ovarian masses where the right ovarian mass is much larger, of more than 20 cm, predominantly solid. And the patient has ascites and bilateral pleural effusion. So this kind of imaging findings need to exclude malignancy. So in this patient who is very young, only 23 years old, and with a very high LDH level, and because it is bilateral ovarian tumors instead of just unilateral, this germinoma should be first considered, correct? It's mainly because of the increased LDH and also bilaterality, because this germinoma can be found bilateral in 10 to 15%. And usually on imaging, they are large, well encapsulated and multilobulated, like what we saw in this patient. It also classically has enhancing fibrovascular septae, which is not usually seen in other types of tumors. So if we see this kind of appearance, the septae, we can be almost, it is quite diagnostic for this germinoma, and when everything fits in. And something that is atypical about our patient is these germinomas usually present with a purely or predominantly solid mass. Cystic component is usually not the main presentation, but in rare cases, they can present like what our patient had. And very commonly, they have speckled calcifications within the tumor, but for this patient, there was no calcification seen. Other differential to consider is ovarian lymphoma because of the very increased LDH, and also because the tumor is bilateral. However, in ovarian lymphoma, most of the time, they are solid, homogeneous instead of heterogeneous like what we have in this patient. And usually the ovarian masses are sort of symmetrically enlarged so that they touch each other like the kissing tumor in endometriomas, right? And then they enhance mildly and uniformly, and they are usually associated with enlarged lymph nodes and bone marrow involvement. So this patient didn't have both, didn't have any enlarged nodes or bone marrow involvement. So this is one point that is against lymphoma also. And other things that lower down the list is Kuchenberg tumor or ovarian metastasis, because patient had bilateral involvement. And the Kuchenberg tumors are actually ovarian mets from stomach and GI tract malignancy, and they usually happen in the premenopausal age, right? On imaging, they have variable appearance and are usually non-specific. So there is no particular sign to point towards this tumor except from bilaterality. And so the way to confirm is to look for primaries in other parts of the body, especially the gastrointestinal tract. So this patient didn't have any other lesion in anywhere else in the body. So let's talk about a little bit on imaging approach in ovarian tumor. So the first imaging of choice is when you detect an abdominal mass and you suspect it is ovarian origin, is ultrasound, right? So it is the initial modality of choice because it's easy to access. It can characterize tumor into cystic or solid, and which is a very good one for that. And it can help also delineate from what organ it arises from, although not always it can manage to confirm, right? So this should be done first. And the CT, thorax and abdomen is usually done only for staging when you already suspected a primary malignancy. And sometimes it is used to confirm whether the mass is ovarian origin, like what we saw in this case. You can see that the ovarian vein arises from that tumor, which will confirm that it is ovarian, and it can help you detect which side of the ovary it arises from. And also, it is sometimes used to identify the primary malignant site when you are suspecting the ovarian mass being metastatic. And it is the best investigation to detect calcification. So certain masses that calcification stands a very important role in diagnosis, like in teratomas, and CT would be a good choice. MRI, abdomen, and pelvis is usually used to characterize ovarian tumor when ultrasound is inconclusive. So there is some value of MRI that ultrasound could not offer is, for example, fibrovascular septae in these germinomas show a low, if you can see here, the very linear and low intensity, low signal septae in the middle here are actually quite characteristic for this germinoma because no other ovarian tumor had this appearance. And post-contrast, sometimes they enhance, right? So this is a characteristic finding if we see it on MRI. CT is not very specific, I would say, and sometimes you may not be able to see. And lymphoma, usually the mass would appear high in T2 signal. Diffusion weighted imaging, one of the sequence in MRI also will usually show restricted diffusion in this germinoma and lymphoma and other types of malignant tumor. So it may help us segregate benign from malignant ones. And the dynamic contrast enhanced sequence can also help us stratify tumors into low, intermediate, and high risk based on the graph that can be plotted from the enhancement pattern of the tumor. So an ovarian tumor can be classified into all these, with high risk being the most likely to be malignant. So in summary, many ovarian tumors have non-specific imaging features. Ultrasound and MRI are useful in characterization of ovarian tumors, and MRI usually is done when ultrasound is inconclusive. CT, thorax, and abdomen is usually done for staging and identification of primary malignancy in the case of ovarian mass, but not so much of characterization. With that, I thank you.
Thank you, Dr. Erika, for that wonderful explanation. I guess I'm going to continue back my presentation and touch about the management of the patients. So for the management of the patient, there are several issues that we have laid out. The first one being the COVID-19 infections. Second is transaminitis with coagulopathy. Then we have the bilateral pleural effusion, and the fourth one is a possible ovarian malignancy. So patient was managed as inpatient. She was initially quarantined in COVID ward and subsequently transferred out to general ward after completion of quarantine. She was managed according to the multidisciplinary approach. She was co-managed with respi team, intervention radiologists, as well as gynecology team. And we had the opportunity to counsel the close relative regarding her condition as well as the plan of management. So for the COVID-19, she was treated symptomatically. She recovers well from COVID-19 infection without any complication after completed her quarantine period. And serial liver profile as well as coagulation profile shows improvement and normalization as the COVID-19 infection resolved. For the bilateral pleural effusion, bilateral pigtails were inserted to allow drainage, and both pigtails were removed prior to discharge, and repeated chest X-ray shows no reaccumulation of the fluid. So this is the chest X-ray after insertion of the bilateral pigtail, and this is the chest X-ray after we remove the pigtail. There's no pleural effusion scenes, and there's a sharp costophrenic angle seen in this chest X-rays. So for the possible ovarian malignancy, we had staging laparotomy done on her. together with right subfinger oophorectomy and left cystectomy, as well as a mentectomy. So intraoperatively, there was ascitic fluids. Uterus appeared normal. There was right ovarian tumor measuring 30 × 20 centimeters, solid and cystic, which multiloculated with irregular surface. For the left ovary, there is cyst measuring 4 × 4 centimeter. Bilateral fallopian tube was normal, and pouch of Douglas was free, and peritoneum normal with no deposit since. Liver and bowel was grossly normal, and subdiaphragmatic surface was also normal. The procedure was uneventful with estimated blood loss of 100 cc. So this is the image of the right ovarian mass. As we can see, it is multiloculated, composed of solid and cystic component with irregular surface area and huge size. This is the left ovary. We remove the cyst. So subsequently, patient recovered well following the surgery, and she was allowed discharge on day 3 post-surgery with a total admission of 18 days. So the histopathology that came back, both ovarian tumors were consistent with dysgeminoma. There were presence of sheets and nets of polygonal malignant cells with uniformly medium-sized nuclei, and numerous mitotic figures were seen. And there was also tumor nodule seen on the omentum. So based on this histopathological finding, we stage the patient as FIGO 3A2, which is a microscopic extrapelvic peritoneal involvement with or without metastasis to the retroperitoneal lymph node. So with that, I thank you. I will pass the presentation back to Prof. Lim.
Thank you, Dr. Rafi. So now we are going to proceed with Dr. Chew's presentation and telling us what is this geminoma and how normally we manage. Dr. Chew, please.
Thank you, Prof. Lim, and the rest of the speakers. Okay, allow me to share my screen first. Can we see? Okay, here we go. We have ovarian dysgeminoma. Okay, before I wrap up, some added information for our patient. Actually, we did a pleural tapping for her, and the pleural tapping result review no malignant cells seen here. That's the reason that we stage her stage 3 rather than stage 4.
Can't hear you.
Wait a minute. I think I was kicked out automatically. I mean, yeah, I share back again. Can you see the slide?
Yes, but not slideshow.
Wait a minute. Okay. Can we see the slide? Can we see the slideshow?
Not yet.
We were a little bit delayed.
Nope.
Right?
Nope.
Yeah. Now can? How come?
Doktor, boleh buat slide view ke?
Tak, tekan slide view. Wait, tekan.
The slide view only on your screen, is it?
Oh, okay, right. Wait a minute. Can you see the slide?
We can see the slide, but not slide view.
Oh, okay. Let me see. The thing will be I share the whole desktop lah, then easier lah. Baik, apa pasal mau share the whole slide? Okay. Okay, I share the whole damn thing. Ayo, susah oh.
Tak nampak.
Tak nampak. Lagi.
Mana proceed ni lah.
Doktor, saya rasa boleh kita teruskan ke? Walaupun tak
I
ada
think teruskan
slide view.
sajalah.
Ha.
Proceed je lah. But you are muted.
Cannot hear you.
Cannot hear you.
You are muted.
Chill, you are muted.
Ya, okay.
Okay. Proceed je.
Okay. Sorry for the technical things. Okay. Ovarian dysgeminoma. Okay, I'll talk about the overview of ovarian dysgeminoma. Overall, ovarian malignancy actually consisted of, we can divide the ovarian malignancy into epithelial cell tumor and also the non-epithelial tumor. Overall, about 80 to 85% of the ovarian malignancy consisted of with epithelial cell tumor. And the remaining maybe about up to 15% actually are non-epithelial tumors, which are subdivided into sex cord tumors and also germ cell tumors. Okay,
Your slide is not moving.
how come my slide is not moving?
It's only on the first page.
This one? Can you see this?
At the side, lor.
At the side only. At the side only.
You didn't move the second slide, is it?
This, okay, this now ovarian malignancy. Can you
Now-
see the?
No, we are still
No.
seeing your slide view, not the slideshow view. I think you better not use the slideshow view lah. You just present with your.
I'm not
your-
using the slideshow view.
No,
Then
you
we
are
are-
you are on the first page only.
Oh, I think I stop sharing. Share back balik. I think there's some delay with the this thing. Okay, can we see this thing?
Yes, now.
Okay, now. Can you see the moving of the slide?
No, it's not moving. It's not moving. You send your slide to me? Can you email your slide to me? I help you to do it.
I think his connection got problem. He's
He's mute. He's stuck.
not moving.
Aduh. Cik Buhari ada dia punya backup.
Hello, I'm back.
Why
Okay,
not?
okay.
Bukan aku asyik di kick out oleh the system only.
Okay, tak apa, tak apa. Teruskan,
Ada
doktor.
backup slide tak? Sebab dia punya computer
Let
problem.
me share again. I think the system keep me out. Boleh nampak?
Nampak?
Boleh.
Can we try the slideshow or we proceed ni lah?
Proceed je.
Okay,
Okay,
okay
can
lah.
ready ya.
Okay. Back to the thing. So, epithelial cell tumor consisted of 80% of all the overall ovarian malignancy, whereby the rest 10 to 50% are non-epithelial tumors. can be subdivided into germ cell tumor and also the sex cord tumors. Okay, what we are talking about here is actually this geminoma. This geminoma falling into the category of germ cell tumor, which comprises of about 3 to 5% of all ovarian cancers. And under this category of germ cell tumor or GTCs, the commonest will be this geminoma, followed by immature teratoma, yolk sac tumor, and also mixed germ cell tumors. Whereby the rest of the 7% of ovarian cancer can be under sex cord tumors. Commonest will be trachoma, granulosa cell tumor, and also the sertolic lytic cell tumors. Okay. As I mentioned, this geminoma is the commonest germ cell tumors, whereby about 33% of germ cell tumors are or is this geminoma. And this geminoma comprises about 2% of all ovarian cancers. And most commonly, about 75% of the affected women are below 30 years old. And this geminoma is considered as one of the ovarian tumor or ovarian cancer among the young women. And we can see here, I show you the ovarian cancer in reproductive age women in United States. Nevertheless, epithelial tumors still consisted the majority of the ovarian tumor, about 42%, and 30% is this geminoma or other GTCs. Metastatic cucurbit tumors about 14% and sex cord tumor about 13%. These are the so-called epidemiology of ovarian cancer in young women in United States. Okay. Talk about the pathophysiology. As mentioned before, 80 to 90% of this geminoma or ovarian this geminoma are unilateral, and about 10 to 50% are bilateral. And the exact etiology has not been determined, although the biomolecular based research has shown that there is loss of function with potential tumor suppressors gene, which means it's TRC8 or RNF139. This is actually for the knowledge of biomolecular base. Okay. The origin of non-epithelial ovarian cancer for germ cell tumors primarily is actually arise from the primordial follicles, as you can see here. Whereas for the sex cord tumor, mainly is actually arising from the tertiary follicle or the medullary ovaries. So this so-called non-epithelial ovarian cancer is different from the conventional epithelial, as the tumor doesn't arise from the epithelial surface of the ovaries. And mainly of ovarian dysgeminoma composed of undifferentiated germ cells and also large vesicular cells dispersed in the sheath or corpse interfused by scanty fibroma tissues or fibrous stroma with variable degrees of ATPR. And the interesting part is it consists of syncytiotropoblast giant cells, whereby these cells usually secreted beta-HCG or LDH. And this actually is one of the so-called biomarkers that we can take to differentiate between this geminoma and other malignant germ cell tumors. And sometimes it consisted of mature lymphocytes, whereby secretes or carries biomarker of CD117, OCT3, OCT4, which can be used as biomarkers to differentiate this geminoma, but it is rarely used for all these type of biomarkers, apart from LDH and also the beta-HCG. Staging-wise, the ovarian dysgeminoma is staged based on the FIGO staging, as similar as so-called epithelial ovarian cancer, whereby stage 1 confined to the ovaries, either one or both ovaries. Stage 2 is actually confined to the pelvic organs, never beyond the pelvic region. Stage 3, beyond the pelvic region, whereby it spread to the abdominal cavity. Stage 4, spread above or outside the abdominal cavity. Okay, as shown by these pictures, actually very difficult to see. Okay, we talk about the prognosis. Interestingly, as ovarian dysgeminoma is different as compared to the conventional epithelial ovarian cancer, whereby we have a very, very good prognosis. 5-year survival rate here for those women with ovarian dysgeminoma confined to one ovary, 96%, and beyond one ovary, about 80%. As I can show you here, the 10-year survival rate according to the stage 1A to 1C is actually confined to 1 ovary, about 96.1%, and stage 2 to stage 4, 79.1%, almost reaching 80%, as reported by one study here. So it actually carries a very, very good prognosis as compared to epithelial ovarian cancer. This is actually a good news here, because our patient has a stage 3 disease. So how about the clinical presentation? There is no specific symptoms for women with ovarian dysseminoma. The commonest, about 80 to 90% of women will have abdominal distension, whether associated with pain or discomfort, and always were associated with early satiety, compression symptoms such as irritable bowel or urinary symptoms. Sometimes due to the rapid growth of the tumor can rupture, or sometimes the tumor can cause torsion. But it is a very, very rare condition whereby a huge tumor twisted. So clinical presentation, our patient presented with quite atypical presentation, because as we taught the medical students, usually ovarian tumor or ovarian cancer, patient will present with solid mass or mixed solid cystic mass. But our patient, from the clinical examination, mainly the tumor is actually cystic component. Investigation-wise, as shown by Dr. Rafi and so Dr. Erika, we can subdivide our investigation into laboratory and also the imaging. I will not talk detail about imaging. So the laboratory test, we usually send the what we call so-called tumor markers. In ovarian dysseminoma, the most commonest biomarker will be the LDH. CA125 will increase if, let's say, patient presented with ascites, as our patient presented with, or there is actually peritoneal inflammatory process going on. So it will increase the CA125. Other biomarkers that can help us to differentiate this tumor will be the AFP or the beta HCG. But if let's say there's actually increased AFP, it points more towards the yolk sac tumor rather than dysseminoma. So in our patient, AFP was not raised, whereby the markedly raised biomarker was actually LDH and also the CA125. So it points towards more the dysseminoma. Imaging wise, I will talk about the so-called iota annex model, whereby it is actually commonly performed by gynecologists to determine by using ultrasound to determine the risk of malignancy. So the so-called IOTA means it's International Ovarian Tumor Analysis. So by using this model, by using 9 components, age, oncology center, the diameters of the mass, the maximum diameter of the solid part, and the locus, papillary projection, acoustic shadow, ascites, and also by using CA125. Bear in mind, the initial development of this NX model was for epithelial ovarian tumor, but this model can be used for other ovarian tumors such as sex cord or the malignant germ cell tumor here. So as calculated by this model, the risk of malignancy was actually 96.8%, quite highly suggestive of malignancy in these patients. Okay, for general, for the treatment part, the conventional, the mainstay management is actually still the surgery. For epithelial ovarian tumor, we advocate comprehensive staging surgery, whereby it comprises of peritoneal washing, total abdominal hysterectomy, and also bilateral salpingo-oophorectomy or mantectomy, pelvic lymph nodes dissection plus para-aortic lymph nodes clearance, and also peritoneal nodules clearance. This is what we call comprehensive staging surgery, or in other words, will be the debulking surgery, or debulking staging surgery. Okay, this is for the conventional epithelial ovarian cancer, whereby majority of our patient will be postmenopausal. But in ovarian dysseminoma, as we mentioned before, 75 to 80% presented in early stage will be mainly stage 1A, and mainly of our patients are young women and thus the fertility sparing surgery is recommended. What is meant by fertility sparing surgery? It is actually what we perform as minimal as we can. So the recommended surgery will be salpingo-oophorectomy for the affected ovaries, plus omentectomy, plus or pelvic lymph nodes dissection if there is enlarged lymph nodes during the surgery, followed by whether we want to give adjuvant chemotherapy depending on the stage of the disease. Okay, before I further explain regarding the so-called surgical treatment, let's look at the so-called prognostic factors. Okay. From this study, it shows that lymphadenectomy or omentectomy chemotherapy subsequently doesn't affect the survival rate of the patient. The only thing that affect the survival rate of the patient will be the stage of the disease, whereby stage 2 to stage 4 actually had less, or poorer survival rate as compared to the stage 1. Bear in mind, even though stage 2 to stage 4, the so-called 10-year survival rate is still excellent as compared to the epithelial ovarian cancer. So we can see here, once the similar study by Shu shows that the 10 years disease-free rate comparing the so-called FSS is actually fertility sparing surgery as compared to non-fertility sparing surgery. Although the fertility sparing surgery, the 10 years disease-free rate is 82%, 82 compared to the non-fertility sparing surgery, 88%, but it is not statistically significant. Thus, by the ESGO and also ESMO, European Society of Medical Oncology, and also European Society of Gynae Oncology recommended fertility sparing surgery for every single patient diagnosed with ovarian dysgeminoma. What we mean by fertility sparing surgery is, for the affected ovaries, we do perform salpingo-oophorectomy. We resected the affected ovaries. If, let's say, the contralateral ovary involved, like this, our patient, recommended will be wedge biopsy or cystectomy. Sometimes just a simple biopsy of the affected, for the contralateral ovary. The reason is we try to do minimal surgery to preserve the fertility function for our young woman. Omentectomy, if recommendation is if there is involvement or macroscopically visible nodules, then perform omentectomy. And if there is enlarged lymph nodes during the surgery, dissect the enlarged lymph nodes, if not to preserve the lymph nodes, plus peritoneal washing. Even though we say we perform fertility sparing surgery, it is still considered a comprehensive staging surgery, because we're still doing the peritoneal washing, take out whichever visible nodules that we can, plus subsequently we send for HPE. So the adjuvant chemotherapy is not recommended for a stage 1A disease. Like our patient, stage 3, it is recommended to have the adjuvant chemotherapy. Even though patient with stage 1A disease, let's say we do not subject this patient for chemotherapy, 10 to 50% of this tumor may recur. However, this tumor is actually very, very chemosensitive, and we can salvage the so-called recurrence by subsequent chemotherapy. The commonest regime of chemotherapy will be the BEP regime, consisted of 3 chemotherapy drugs: bleomycin, etoposide, and also the cisplatin. Okay, BEP regime, for there are actually many chemotherapy regime. The commonest recommended regime will be BEP. 3 cycles for fully resected disease, that our patient, because it involved the stage 3, involved the contralateral ovaries and also the momentum, so it's recommended for 4 cycles. And depending on the tumor markers, LDH and also the beta-HCG and CA125, sometimes we can give extra 1 or 2 cycles of the chemotherapy. So other regime will be PEI, JEP regime. PEI is cisplatin, etoposide, and IFOS. JEP regime, we replace the cisplatin with carboplatin. Even though these 2, cisplatin and carboplatin, are platinum-based chemotherapy. JEP regime is recommended for ovarian dysgeminoma for children. The reason we replace cisplatin is to reduce the cytotoxic effect to the ovary. Okay. How about the fertility after treatment? Bear in mind, we perform surgery, we give chemotherapy to this patient, so the chance of the natural pregnancy may reduce due to pelvic adhesion, damage to the contralateral ovaries, the chemotherapy toxic effects. Nevertheless, 75 to 90% of one study shows that these women can have a normal pregnancy after fertility sparing surgery with or without chemotherapy. Having said that, in our center, we can offer oocyte cryopreservation for this type of women, whereby assisted reproductive technique or ART had no negative effect of the tumor recurrence. So actually, we did offer our patient for oocyte cryopreservation. However, the main issue here is actually the cost. Hence, we did not agree for that. But we can actually dormant the ovaries or before we give the chemotherapy by using generation analog here. How about the second loop surgery? So the America ACOG not recommended as a standard care of the surgeries for the second loop surgery unless patient presented with persistent elevation of tumor markers after the first surgery plus abnormal findings from the imaging. So in our patient, we advocate, even though it's stage 3, we advocate chemotherapy for her. I think now she already completed the second cycle of BEP regime here. So we are waiting for another 2 more cycles, whereby the tumor marker shows actually a reducing trend, the LDH and also the beta-ICG. So the follow-up, how about the follow-up? 75% of the occurrence were during the first year. So the recommendation will be exactly like the so-called epithelial ovarian cancer. So 3 monthly for the first 2 years and the remaining third year, 6 monthly and subsequently annually for every year after that. By using clinical examination, every time patient come for routine follow-up, examine patient's abdomen, see whether there's any mass, palpable mass, okay, plus the imaging and also the tumor markers. Tumor markers here is a little bit different as compared to the epithelial cancer, whereby here we solely depending on the LDH rather than the so-called CA125. So with that, thank you.
Thank you very much to all our 3 speakers. I think if you have any question, please type in the chat box. I think we only probably can allow 1 question because of the time constraint. And following this, later we are going to show a quiz in the Kahoot for the medical students. So far, I don't see any question in the chat box. Anyway, may I ask Dr. Chiu 1 question for the interest of the medical students? Just how you do just how you did mention about GnRH analog before chemotherapy. May I just ask, how does it help this patient in terms of the fertility preservation during chemotherapy?
Okay, for the so-called GnRH analog, actually it quiescen the function of the ovaries. It does, although some studies shows it does help in terms of the fertility, preserve the fertility, but some studies, majority, the latest studies show it does help in certain situation. So the best still is actually oocyte cryopreservation or the tumor cells cryopreservation, whereby it is actually offered in our center.
Yeah. So the best is still if you can preserve the oocyte, that will be still the best. Because I think GnRH analog basically is to suppress the ovarian tissue so that it doesn't become active and mitosis, meiosis doesn't happen.
Yeah.
And chemotherapy basically is mainly targeted towards those cells which is actively mitotic and it works on there. So it may and may not be helpful anyway. All right. So I don't see any questions in the chat box still. So with that, again, thanks to all the three speakers, and perhaps we can show the Kahoot for the medical students. And then we shall end this CPC. Thank you.
Terima kasih Prof. Shan. Saya sharekan dulu untuk CPD point untuk doktor gunakan apps MMA ni lepas ni kita ada poll lah. Kita ada poll. Sorry, bukan poll.